Hello, my name is Andrew Lane. I'm from the Dana-Farber Cancer Institute and Harvard Medical School. This presentation is on pediatric BPDCN and the use of Tagraxofusp in children. BPDCN is more common in adults than children. The average age of diagnosis of BPDCN is in the mid to upper 60s. However, there are pediatric cases that have been reported. This study from Kim et al. In 2017 collected all of the case reports of pediatric and adult BPDCN that they could find that had clinical information attached. And here's what they reported. First, you'll notice this bimodal age distribution of cases of BPDCN. This is 357 cases, 283 adults and 74 children. And you can see that, like acute lymphoblastic leukemia, a related leukemia that also has a bimodal age distribution, BPDCN has a peak in adults around the age of 70 and a peak in children around the age of 10. The study looked at the epidemiology and the outcomes of BPDCN in children as compared to adults. And here are some of the important differences they reported. As has been mentioned in other lectures, adult BPDCN is a very male-biased disease, approximately 3-to-1 male to female in incidence. What they found in this series was that adult BPDCN was a 74% incidence in males, but the pediatric cases were only 55%. This was statistically different. They also found that children had a higher complete remission rate with treatment compared to adults, 86% in kids versus 52% in adults. And children also did better once they achieved a remission, in that they had a lower relapse rate. Here reported a median follow-up of 20 months, 27% relapse rate in children and 57% in adults. The overall survival that they reported was not statistically different, but there appeared to be a trend toward improved survival in children as compared to adults, with a 12-month overall survival in children and 6 to 7 months in adults. So while there are clear differences in response to therapy and relapse rate in kids and adults, you can see from this that the overall survival in both populations is still quite poor, suggesting the need for new therapies. Notably, there was no difference between pediatric and adult BPDCN cases in the organs affected at the time of presentation, meaning whether the disease was in the skin only or skin and other organs, and no difference in whether or not there was central nervous system involvement. Here's a little more in-depth data on response to therapy for BPDCN in children and adults. This is the proportion of patients who achieved a complete remission with first-line treatment. Like has been reported in adults, it appears that in children, the highest rate of CR is when patients are treated with an ALL, acute lymphoblastic leukemia-like chemotherapy regimen. And although these were the highest remission rates in both kids and adults, again, the children did better. With ALL-like regimens, 93% achieved a CR and first remission compared to 77% in adults. AML-like chemotherapy and lymphoma-like chemotherapy had poorer rates of complete remission in both children and adults, but in both cases, children had higher rates of remission than adults. As mentioned on the last slide, the rate of relapse after complete remission was lower in children as compared to adults, 27% versus 57%. They calculated that each year of older age increased the risk of relapse or death in patients with BPDCN by approximately 2%. So the conclusions from this data are, like in adults, ALL-type chemotherapy regimens are preferred for children with BPDCN. Unlike in adults, however, where stem cell transplant is recommended for adults in first remission, the recommendation for children from most pediatric oncologists is to reserve stem cell transplant for pediatric patients after the first relapse, in other words, in the second remission. So pediatric patients who achieve a first remission with initial chemotherapy are often treated with more chemotherapy in consolidation and maintenance rather than stem cell transplant. What are the reasons for this difference in outcomes between children and adults with BPDCN? One are probably the reasons that we see across many diseases, where children have a better tolerance for intensive therapy and fewer medical comorbidities compared to adults. But there are data to suggest that the biology of the disease might actually be different in children as compared to adults as well. This is a study from Suzuki et al. From 2017. They performed RNA and DNA sequencing on BPDCNs from children and adults. There was no difference in the pathology characteristics of the BPDCNs, but when they looked at the genetics, there were clear differences. First, they reported MIB rearrangements. These were DNA rearrangements involving the oncogene MIB that were in all 5 of the cases of pediatric BPDCN that they studied, but only in 4 out of 9 adult cases. In contrast, all of the adult cases had mutations in genes associated with aging and myeloid malignancies, such as TET2, ASXL1, and the others listed here, whereas none of the pediatric cases had those gene mutations. So this suggests that there may be underlying biological differences between BPDCNs arising in children and adults. Tagraxofusp, or SL401, is a diphtheria toxin interleukin-3 fusion protein that was approved by the FDA for treatment of BPDCN in 2018. The seminal studies that led to approval of Tagraxofusp were only for adults with BPDCN. However, this small case series from City of Hope Cancer Center in California in 2018 reported the use of Tagraxofusp in 3 children with BPDCN. Here are listed the characteristics of the 3 patients, a 10, a 12, and a 15-year-old with BPDCN who were treated with Tagraxofusp. 2 of the patients had received ALL induction chemotherapy and 2 different salvage chemotherapy regimens in relapse, whereas the 12-year-old patient had not had any prior therapy for their BPDCN. They reported that the treatment was safe in children. 1 of the 3 patients developed mild capillary leak syndrome but was still able to continue treatment. And they reported that they saw efficacy in 2 of the 3 patients. On the right, you see pictures of the skin and bone marrow responses in patient number 2, the 12-year-old. And that patient was able to go to a stem cell transplant after receiving Tagraxofusp. So on the basis of this data, the FDA approval for Tagraxofusp includes pediatric patients. So to reiterate, in December of 2018, the Food and Drug Administration approved Tagraxofusp for BPDCN, and that approval includes adults and pediatric patients aged 2 years and older. The dose and schedule is the same as recommended for adults, 12 micrograms per kilogram, once daily every 5 days, first 5 days of a 21-day cycle. And cycle 1 should be administered in an inpatient setting for safety monitoring, just as it's recommended for adults. So in summary, while BPDCN primarily affects adults, there are pediatric cases. Outcomes in children are better than in adults, which leads to a different clinical approach, most importantly, to perhaps not recommend stem cell transplant for children in first complete remission. The disease biology may be distinct in children, and Tagraxofusp is active in children with BPDCN. Thank you for your attention.